A very good evening to you. You're with us. My name is Sophie Matovu. Taking you through tonight's talk show, where a focus of discussion is Ebola status update. Now, with me in studio to shed more light on this topic is none other than Dr. Alex Ndiabachira, who is the incident commander, Ebola virus disease, and he is on the COVID on that response team, and was also part of those. You know, they pick the best. He was the COVID-19 virus. This team under KCCA, and we know that we can't afford to sit down and sleep when the virus outbreak is there. So how prepared are we, Kampala, as a city? Doctor, a very good evening to you, and thank you for making it for the show.
Thank you. Good evening, viewers.
Okay. Doctor, I would not like to take it for granted. I want you to break it down into a simple layman's language. When you talk about Ebola virus disease, what are we talking about?
Thank you. We are talking about, like you said, a virus disease. We know that most viruses do not have a cure, but they have mechanisms in which we can help the body to cope up and kill them. So usually they are killed by the body. So this is one of those viruses, and that eventually in late stages it causes bleeding from most body parts, including those that usually do not bleed, such as under the skin, the eyes, and many other organs, including the internal ones. Initially, you start with non-specific symptoms. I don't want to call them the normal symptoms, but they are common symptoms: headache, fever, feeling sick, feeling unwell, body weakness, muscle aches. That's the early infection. And then the symptoms worsen into the ones we call watery symptoms, wet symptoms, where you may have diarrhea, you may have symptoms related to urine, blood in urine, blood in stool, and then bleeding before usually the last step of life. Yeah, so that's generally that's what it is.
What is the status right now in Uganda as a country?
Uganda has built capacity to respond to outbreaks from infectious diseases, especially the ones we call hemorrhagic fevers, this Ebola and its cousins and sisters. So that's why this outbreak has not devastated us like you would expect, or like previously, because of the systems that are in place from the previous outbreaks. For instance, for this outbreak, whereas it is known that it kills between 40 and almost 100% of the people it infects, this time it has killed about 39%, which is, death is death. Even one is really very hurting, but we are very excited that we've lost a few people on the lower margin of the people it should kill. We don't take credit alone. It's also the alertness of the community coming very early when they just feel very sick, accepting to be treated, accepting to be withdrawn from a community, to be managed, be actually accepting that this disease exists. You know, they can just say that it's not there and you are dealing with that. So as a result, from the time the outbreak was announced, and that was on 20th September, we have only 142 cases spread in 9 districts. And I'm sure you are aware that some districts have got 1 case, but because the community is alert, the systems are alert, that case does not infect any other person. That's very serious credit. And we have 80 out of those 142 have recovered, and about 56 we've lost them. Amongst these, we have 18 health workers who have been infected. Unfortunately, 7 of them have died in the line of duty.
Now that you have said that, I'm even feeling sad. Okay, certain times it's inevitable. But what plan do you have in place as KCCA to ensure that, you know, the health workers are safe? We can't say that that happened to them because they were not safe, because I believe all the protective gears are available to them. But, you know, psychologically, yes, you're in the medical fraternity, but you might also feel like, why should I put my best foot forward? How safe am I?
Yeah, exactly. You know, the probability that you will get infected by an infectious disease, which spreads from person to person, especially like Ebola spreads by touch, so much depends on the length of exposure. If you're working on these patients every day, the probability that at some point you get exposed also increases.
Yes.
A one-time visitor cannot be at the same risk as this health worker who is, that's the daily work. You are facing the virus every day. So those who are not infected out of not doing their best, they did their best, the system did their best, and that's why you see out of, I don't have the number of the health workers in the response, but out of all of them, you only have 18 infections. And out of 18, you just lose that small number. With the right away from the highest level, the president has spoken to health workers. The minister has weekly, I can call it continuous medical education, but also morale boosting talk with the health workers. This is virtual because you know that they are all over the country, but also we don't want mass gatherings. So she speaks to them. Apart from being the political head of the ministry, you are aware she's also a pediatrician,
yes,
and practicing doctor and licensed to practice medicine in Uganda. So she speaks to them from the angle of being the head of the ministry, but also being a technical person in the area, telling them what to do. She has been on the front line. She's a frontline health worker. She visits the epicenter many times. She has visited Kampala, much as it was not the epicenter. When we had cases in schools, she was there with her team, talking to them about what they need to do. Well, you're a communication person, you know that you have to say something several times for it to stick. But that aside, we have so many interventions with support from the Ministry of Health, from other ministries, but also from partners, from WHO, from CDC, from all the partners that you know that implement health interventions in Uganda, to put mechanisms in place to protect health workers. These include making sure that they have adequate knowledge of what they need to do, and this knowledge keeps changing with how the outbreak is moving. An outbreak changes on a daily basis. That's why there are meetings every day. Today you have no case, tomorrow you have 10 cases. Today you have 10 cases, tomorrow they have recovered. So you keep updating. So we give this information regularly to the health workers. Supplies with personal protective equipment appropriate for the task each health worker is doing. In a response, different health workers play different roles. And as they play those different roles, we make sure that they have the protective gear to assist them execute their responsibilities. If you are an ambulance driver, what sort of protective equipment do you need and gear versus someone who is coming for contact tracing versus someone who is going to operate on a patient possibly who has Ebola or doing any procedure with someone who has Ebola. That is available. The other thing is priority treatment. Not that we don't prioritize other health workers, but when health workers contract Ebola, they have a separate treatment unit for them.
Okay.
And you must have heard that previously they were getting treatment in Fort Poto, and the community was actually wondering if they are treating in Mubende, why are they bringing Ebola virus now to Fort Poto, where it is supposed to be? But that was a treatment center for health workers, so that if you fall sick, you're not then admitted on the same ward with the patients you are treating, because that demoralizes patients. They don't want to see their health worker fall sick. So usually when they fall sick, they are managed elsewhere. The treatment they receive is the same as the treatment anyone else receives. It's not special treatment. It's just the treating them from a different place.
You talked about the treatment units. Which ones do you have specifically gazetted in Kampala, in your district? In case you have a situation and we have to, like I remember this time when during COVID, the numbers grew, that you ended up having Nambole as one of the treatment centers.
Yes, so for Ebola virus disease, the treatment, let me call it management for the sake of this discussion, happens at different levels. So when we identify a patient, we usually call them case. It's not a case in court or a case for taking to school. It's a patient. We want to know who they have contacted, whom they are likely to have infected. So those ones, we call them contacts. And for infectious diseases, lethal viruses like Ebola virus, we do not leave those people in the community, because you know that in African setting, it's difficult to avoid physical contact. So we usually bring these people in one place in isolation, in an isolation facility. So you would call that maybe level 1 of treatment now. So at that point, these have no symptoms. They are just like you and me. But because they got in touch with a patient, we think they may get infected and infect others. And because we managed that process very well, that's why you see that disease did not move quickly. Whoever would get in touch with you, we get him, we talk to them, we say, you know, we want you here in isolation. So we had isolation facilities in Kampala, and that was in Mulago, National Mulago Hospital. There's an isolation facility. And then in Entebbe. Those were for the Kampala metropolitan area. The city, Entebbe, Wakiso, and Kampala. And Mukono. Then we had plans for in case it escalates and we have to isolate so many people. What's the plan? So we established other isolation facilities, temporary ones, and they are there just in case we get there. We are not there, so they are not working, but they are ready to receive patients just in case we need to isolate people. Then Entebbe, in addition, has a wing for now treatment. Now that's level 2. Those who have now been confirmed sick, they have progressed, or they have been detected and they are sick and they are receiving treatment. Now please note that in these isolation facilities, even when you are there, you are also isolating from the other members you have in isolation, so that in case you fall sick, then you don't infect them. Otherwise, we would never finish. When one of them falls sick, all of them start contact tracing afresh. So we ask them that, yes, you're here, but while you're here, avoid contacting the other clients that are actually there, much as all of them have no symptoms. So those are the facilities we have for the Kampala residents.
Now, when it comes to, you've talked about the progression and somebody gets to that level, because at least you've got cases that you celebrate for those who have cured from the Ebola virus disease. What is the main cause of death for those that have not been able to make it?
Now, death is a factor of so many things. And one of the factors that predicts death very, very well is age. The older you get, the more the chances that you will actually die. Even in normal life, forget the Ebola virus disease. So people fall sick, and whether they will die or not depends on so many factors. And one of them is their age, the older they are, but also very young children tend to progress very quickly. The other factors are how healthy are you as you fall sick. Are you very healthy? Did the virus catch a very normal person who was extremely very healthy? The others are if there are other underlying diseases. It is not written anywhere that you have one disease. So you have Ebola virus disease, but you also have hypertension, you also have diabetes mellitus, you also have HIV, you are also on medication for several other things, or you catch the virus when you have just been operated, maybe you had an accident. All those are factors that will lead to some people dying while others. But the most important ones that is within the control of the community is how fast do you seek for care when you feel unwell. If you are completely normal, but you just decide to stay home, and yet you know most likely you contracted the virus, and then you present it to the health workers, the opportunity window within which they can intervene to help the body catch up is very limited. So chances are that if you present late, you already have the advanced symptoms. You are away from these usual symptoms of fever, headache, muscle pain and weakness, loss of appetite. You are now vomiting blood, you are bleeding. Chances that the health workers will secure your life are very minimal.
Oh, wow.
So our representation, if anyone out there feels unwell, they need to contact the health worker very fast.
Now, who is at risk of contracting this virus?
Everyone is at risk of contracting this virus. Every district in Uganda is at risk, just that the risk is slightly different, some at higher risk. For instance, if you look at places, people who are in places where there is high densification, there are too many people, like in markets, in slums, even if it is a stable population, chances that their risk is higher compared to, you can take an example of informal settlements and compare them with upscale Kampala, like Nakasero, Kororo. You clearly see that the risk is higher where you have that congestion. But also places with high transient population, people who are moving through. These are arcades, traders, these are tax parks, bus terminals, public transportation, border riders. They are transporting people, they don't know where they have come from. Those ones are also at a higher risk. Of course, you have your health workers and all other people working in the environment where we are treating these patients from. Their risk is also high. Of course, the advantage with them is that they are trained on how to avoid contracting this virus compared to the rest of the population. But also they know that they are dealing with the virus. If you know that you are dealing with an enemy and this is the strength of the enemy, you are more conscious compared to someone who doesn't know that he's dealing with the enemy. So the health workers have that advantage of knowing that I am here treating Ebola, and therefore I have to do A, B, C, and D.
Okay.
Yeah.
Then what are the myths and misconceptions? Because previously one of them that stood out quite well is when somebody thinks and doesn't believe that they actually have the virus and they think they're being bewitched. And that is where they were running to the witch doctors to be able to seek intervention.
You know, one of the reasons actually people run to the witch doctors and traditional healers, we call it the folk sector. Even if you talk to doctors, you actually find that it's not that doctors go there, but you'll find that their friends actually consult their wives, their spouses, before they consult the doctor himself.
Oh, wow.
Yes. So that folk sector is very strong. It's not that they don't believe that Ebola is there. No. This is their first point of care, even for other illnesses, and research shows that. Even for other illnesses. It's just that those illnesses are not outbreaks, so you don't get to know. So they end up presenting with hospital later, when the witch doctor, traditional healer, the pastor has failed, and they say, it's serious now, it needs hospital. So it's partly, of course, you're also right that some do not believe that the disease is there. Others believe that this is likely not a disease. And the reason is because it spreads by contact. So it will kill you, and your son who looked after you will have contracted it. So it will kill him. And if the mom looks after the son, it will kill the mom. So how else would you explain something that moves like that in a home? Kills father, 4, 5, 6 days later, kills mommy, you know, and maybe your uncle throws in something that, you know, the other time I told you that you will see me, you are just starting. Now, bizarre statements like those, when you are already emotionally broken down, you now interpret them, you say, now he has really managed me. So convincing that person that, look here, you are dying from this disease, even if you test them positive, is very difficult. But we've not had much of that for this outbreak. We had much of that for COVID. So the risk communication and the education that happened during that time paved the way for this. I think God knew that Ebola was coming. So we have not had too many people saying, no, it's not there. There are families that it has devastated. Like I said, you think it has killed one person and you're like, it's one person. When you look at the story behind this one person, you actually realize that this one person is 1 million people. So we don't most times look at the numbers. How many people has it killed? No. Has it killed someone? What is the story behind this person it has killed? When you listen to the story, you realize the numbers don't make sense. Stories behind make sense.
Okay. Then what's the incubation period for the virus?
Now this virus, first of all, the incubation period is that period when you have it and it's incubating. Okay, let me use the same word. It's growing, but it has not yet put you down. You are not yet sick. You have not yet developed symptoms, so you feel okay. And it can range from 2 days to 21 days, 3 weeks. So that means that you can get infected. You cannot celebrate until 21 days are over, when doctors are monitoring you, when health workers are monitoring you. I have told you the initial symptoms are headache and flu, which most of us, headache, fever, loss of appetite, which we usually get.
Body weakness.
Even when someone annoys you, you can lose appetite. So these symptoms, someone will not easily think this is EVD. They will say, some headache, yesterday they did not pay my salary. Maybe this
take
stress,
some
school
Panadol.
fees. Panadol, and then it goes down, it comes back. You get it? So unless someone is monitoring, even after 21 days, you can't celebrate because you may still those simple symptoms are actually symptoms related to Ebola virus disease. And that is related to when the outbreak is actually, when we say it is now over. Because many times you will hear the community saying, we have not got a case for a week and these people, what are they doing? But because we know that we have looked at how it behaves, we know how it behaved in West Africa where it lasted a year. You can celebrate when you're about to complete the first 3 weeks, you get a case and you start afresh, running up and down. So that's why we combine 2 incubation periods. So for you to say that it seems now we can start celebrating, from the day you get the last case, you count 21 days. If you don't get a case, you start, you're like, okay, seems the interventions are working. You start counting another 21 days. So in total, you need 42 days without getting a new case to say that now it is over. So the public needs to know that we will start counting those days when we get the case we think is the last case. 21 days are over, another 21 days, then we can now celebrate. Before that, it's
now
not time for celebration.
That brings me to this question. Bwenden Kasanda, and 21 days, 42.
Of lockdown?
Yes, another 21 days.
I want to get you clearly. 21 and 21. Or
21 and 21, that's 42.
Yes.
Now there is another 21.
So yes, so the initial, you see these lockdowns or restrictions are put with a purpose. Sometimes there is an aim. Now we know that most infections, especially those that go through physical contact, mobility is a very serious factor in their distribution. You can disperse an outbreak in this country in 3 days because the population is highly mobile. Especially like this one that was very close to the city. Mubende, where it started, is about 2 hours. If you have a bad car, a good car, and with how we drive in Uganda, which you know, if the Uganda police is not on the road, 1 hour, someone will be parked in Kororo. So yes, so you have to be extra conscious to make sure that mobility is minimized with very minimal impact on the social well-being of the people. So you introduce a lockdown, but you have a mechanism to mitigate all the negative effects of the lockdown. Otherwise, you will cause more undesired effects from the restrictions. Because people are not working, they can't move, and you have not provided, let's say, ambulances to evacuate them in case they want to go to hospital. So you may lose people from other illnesses, and that's not the aim of the lockdown. So the initial phase was to control the outbreak from skyrocketing. So we can't count that anywhere as part of the 21 days that I'm talking about. The 21 days start when you have a case and you think this is the last case I have got. Then you're like, okay. And how do you know? We have what we call an epidemic curve. So an epidemic curve, you plot the cases you're getting every day against the date. Today, how many days? Yesterday, how many? 4. So you will see it coming down. It keeps telling you that, seems you're going down, you're going down. When you start getting the last cases, then you know. You get a case today, 2-3 days, you don't get another case. Then you're like, should I start counting? Then you can actually start counting. So the initial restrictions and lockdown had nothing to do with counting if the epidemic was ending. It was for controlling the epidemic because at that point it was skyrocketing. Now you want COVID can skyrocket. Why? It spreads quickly, attacks so many people, kills very few. Out of 1,000, out of 100, it kills 2. That can spread quickly because you know at the end of the day I'm not going to lose lives. Ebola doesn't spread as fast as COVID, but it kills its catch. Out of 100, it can kill 100. It has potential to kill all the 100. It can kill from 40 up to 100. Now, that's not a pathogen you will joke around with. Because if it runs out of control, and like COVID, which will kill just 2%, this can kill everybody who will remain in Uganda. So you have to make sure it doesn't spread quickly. And that's why some of those measures come in place. And you know our slogan? Do you know our slogan?
No.
It is better to overreact than to be sorry. So I would rather kill a mosquito with a bomb than
That's
trying
the
to
slogan
slap
for the
it.
medical personnel?
No, for outbreak management.
Okay.
When we are dealing with very little pathogens, we would rather overreact. I would rather bomb a rat than using a stick. So let's also contextualize that. Why slap a mosquito when you have a bomb? Just bomb it. You are sure that it has died.
Now, in terms of the plans, you said, I'm very impressed when you talked about earlier in the show that you are every day ensuring you keep on talking to the health workers and the medical teams out there. But we have these people who are down and closer to us. What plans do you as KCCA have for the VHTs?
Now, if there are any people at the center of this response, it is the Ugandan out there. We've got them fully engaged and shown everyone that this is a problem for all of us to sort. And they have responded. So on daily basis, you monitor the outbreak and its behavior. You also monitor the behavior of the population, of course. You want to know if indeed they see this as a problem. If you are seeing it as a problem and they don't see it as a problem, then there is a problem. Okay? So we acknowledge the fact that the public has really joined us, the community has joined us and seen that this is a real threat to their lives, their livelihoods, economy. And the discussion in the recent past has been about they may lock us down, they want to lock us down. What
fear.
can we do to make sure we are not locked down? We were approached by everybody from all. That is very good. People are engaged and they want to know what they can do to prevent us from moving to X, to point Y, to point Z. And they have complied. The whole of Uganda has complied. I think this is one of those days when all of us have been rallied behind a common enemy. No one is thinking about anything. And that's why you see in these few days, I think maybe we're about day 60, the outbreak is already in, not exactly gone, but it's in a state where you can breathe. I can see right at the end of the tunnel. So when we monitor the behavior of the outbreak, we adjust interventions to make them appropriate for the stage of the outbreak. Are cases many? Where are the drivers now? Where are the risks? This risk keeps shifting. This week you have it so much in the tax parks and transportation, and you intervene, it shifts to the passport office, to driving permit distribution centers, and other crowded places. The next day it shifts to schools. Before you know it, it's now in the markets. So you keep studying that and intervening based on where risk is worsening or is increasing. So in line with that, we rally the community behind. That comes with risk communication, making sure that we have made sure that we raise the risk perception so that everyone sees that actually this is our problem. We have deployed VHTs and LCs at community level. If you stay in Kampala, most likely you must have seen these people come to your home or your village, or you must have heard that they are moving around to make sure they can reach all homes. We combined that with what we call active case search. Now, active case search is where we actively, or the community is not reporting that there are cases. Let's actively look for these cases in the community. So we move house to house, asking if there is someone with fever or symptoms related to EVD, and if they are there, we have an algorithm of what steps should be taken. We also activated active case search in all health facilities by reviewing registers to see the records of the past 3 weeks. Who fell sick and came here and had symptoms related to Ebola virus disease. If we find them, then we follow them up. Are they still sick or they got fine? That has happened. We made an additional step and started testing all bodies that die in Kampala mortuaries. Any hospital mortuary, that is combined with community death. So a community death, the VHT or the local leadership alerts the call center, the toll-free call center. We evacuate to the mortuary, take off samples, test. If it's not EVD, we hand over the body back for burial. If it's EVD, we have not got EVD. Then we follow the steps of EVD. I can announce that at least for the Kampala metropolitan area, we have not caught any infection from those interventions. So we proceeded now to try to reach out to more people with information. And this is how you'll be seeing drones mounted with speakers over markets and some informal settlements. This is going to happen as soon as possible, if it has not started, because we have it in plan. We have, we're going to activate these billboards you're seeing that are showing wonderful things. They will also show some wonderful messages about Ebola. And these messages are not just from us. These are messages from you. We are going to record those testimonials from the community. Whom do the people want to listen to? That's the one who will speak to them. We have our survivors, those who have been treated, and I want to request you to host them here. They are available. They want to speak to the country. They want to address us about what did they find in isolation behind there, where they go and no one else is around. They have a story to tell the nation that I was here and this is what happened. I am back, alive and kicking. They are part of us. They are responding. They are speaking to people. I contracted Ebola. I did ABCD. I was treated. I am back to normal. I am working. We have stories. You are aware that we have a child who sat P7. You are aware? Should host these people. Okay? Treated them. Like I said, their stories behind the numbers are more touching than the numbers. This was a child who tested positive. Classmates were all isolated. The parents' nightmare, of course, is my child going to sit period? You know, as parents, we want our children to excel. Now here you are, your child is at home, isolated. So we had support from partners, from UNICEF, from UNEB, from the Honorable Minister for Education, the First Lady. UNEB granted them permission to sit exams from a different place, not their center. That is not a center. This pupil was treated and sat the exams. Or the classmates, during follow-up, sat exams. These are stories behind the numbers that sometimes we don't get an opportunity to tell the people. Host these people, and they speak to the public.
Now here comes this, what's the story when it comes to the vaccine? I'm meant to understand there's would I call it a trial vaccine?
Yes, you're right, call it a trial vaccine.
And who can easily access it?
Now, it is a trial vaccine, like you said. Use the most correct name. I see you are now part of the response team. So being a trial vaccine, it's going to be administered in a clinical trial setting. A clinical trial is you have a new vaccine. They are candidate vaccines. We call them candidate vaccines. They're about 3. And they have been proved. The first steps before you try them in healthy volunteers is to make sure that they are safe. So the safety profile is known and is okay. At this point, I need to say that we are rated to animals. Animals are our cousins. This is one everybody should know. We eat them. I think that was rebelling against them. That's why now they infect us. Like Ebola usually comes from animals. These are our cousins. When we test something in a rabbit and it works, in a chimpanzee and it works, chances are that in a human being it will not cause trouble. It may not work the same way, but it is safe. So these have been tested in our relatives, and they are very okay. So we now want to test them in people and see actually if it works. And this is a normal procedure in vaccine development, in drug development. Each drug you're swallowing, someone first swallowed it in a trial format, but this is done in a very controlled environment, and we call that a clinical trial. So this is going to be administered in a clinical trial setting, and therefore I cannot say that I'm calling upon the public to come for vaccination. It's not going to be available to the public for consumption until a stage when it is approved. So this vaccine will be administered to the contacts, those who have contacted a case. Of course, our dilemma is I mean, we are working hard to make sure we get to 0 with cases, and yet we need contacts to administer the vaccine. But there are other mechanisms of testing a vaccine, even if you do not have. So that is not yet exactly rolled out. I am sure the minister is going to address the country about that. But I had to say something since you asked about it. And now what I need to add is that we had some queries here and there related to COVID vaccination. Where was it tested? Here is an opportunity for Ugandans to participate in testing the vaccine they want to be used on them in future and other people. So that we don't start saying, where was this vaccine tested? Because we will know now that this vaccine, Ugandan has participated in making sure it is safe and can be used in people.
Then what about the fact that, like, given who we are, the Africans that we are, there is that bit of the traditional herbs, nogawa no nogawali, mix this, concoct with this, and then, you have your solution and your remedy.
For treating Ebola?
As in for people, yes. They believe and they will think and even carry it. You remember how we all became doctors during COVID-19?
I know how we steamed.
We steamed, we did everything, name it, in the book.
Yeah.
How are we planning to deal?
Of course, we will remain, like we are African and we will remain African. We're not going to become something else. So we have to find a way. We have to know that medicine, even the medicine that you use to treat a certain illness, becomes a poison if not taken according to the instructions of the manufacturer or the doctor. Overdose kills people. There are people who have committed suicide with overdoses. So the biggest problem with those herbs is the fact that you have to take 2 cups, you actually take medicine and you get satisfied. Now what sort of dose is that? You can't eat 3 cups of medicine. And you're patient, you need to eat after that because the doctor will have told you now you need to eat. You are satisfied with the, what's the name of one of them? 3 cups. Mururuza, you take a jug, you are full. You get emaciated, by the way. If that is the dose you are supposed to take 3 times a day, you're not going to eat. Now where are you going to get the nutrients from? So what I'm trying to say is that the doses are not known. The concentration is not known. How many leaves should you put in a cup? No one knows. The active ingredients are not known. Now, how do you use that medicine? So medicine works only in known quantities, but also when you know. So those things are not pure. When they are not pure, that's why you will see them saying, this tea cures 100 diseases. Indeed, indeed it attempts 100 diseases. Because you're going to pick the thing the way it is and put it in a cup and swallow.
True.
I don't encourage anyone to use those things. They have no known doses. They have no proven efficacy. No one knows if they work.
Very true.
So we will remain Africans, but we have to discourage some bad practices.
Very true, doctor. What did you say to that? Oh, sorry, get that's very, very true.
Yeah.
Now, in terms of the challenge, have you faced any challenges during the intervention and trying to manage this outbreak?
Oh, challenges are there, but we and this is what we usually tell people, even the community, we are problem solvers. Challenges will always be there. No one, first of all, for instance, knew that there was going to be Ebola on 20th of September. No one knew. True. So now, if you don't know, and most of the supplies you're going to use are not normal things that you plan for usually. So you expect that when now they say that there is Ebola, to mobilize resources, this includes people, includes every other supply, it has to be challenging because you do not have any budget allocated to this at the start. And you know that we work on a budget that is approved and appropriated by Parliament. But no one knew there was going to be Ebola. So as you start responding, you are also starting this process to get resources. Definitely in the early days, you really struggle. But we usually have people we work with, the partners, call them partners. These are very important people. They usually have easier routes of accessing resources while we are going through the normal government system to access some of the supplies. Some of these supplies have to be imported. You can't import something, for instance, from Japan in 2 days. No. First of all, also quantifying. You don't know how the scope of the initially you don't know how it's going to behave with all the scientists you have. Sometimes it's difficult to know its behavior. We tend to get those challenges. Initially, of course, we also get challenges with people accepting that, believing that actually this outbreak is for real, is there. Especially when it is still far away from you in Mubende and you're in Jinja. You can't think that it's going to jump all districts and be found in Jinja. So we have challenges related to, being believed that actually this outbreak is there. We are in denial. You know, denial usually when you're given bad news. There is always that room where you keep oscillating, denying that, is it really Ebola? Who ate a monkey? Who ate a rat? We are looking for that person who ate an animal. They want to blame, really to, you know, to blame someone, the first person who brought it. But of course, we don't choose to fall sick. So there are those challenges. Of course, the other challenges are related to the workload on the health workers. At the start, you start with what you have. So you start with the health workers you have. You're establishing new health facilities, the ETUs, the Ebola treatment unit, ETUs Ebola treatment unit, that need to be staffed with health workers from all cadres. When I say health workers, it starts from just the cleaner to the senior consultant. It's a whole, to make sure a patient is catered for at 360 degrees. So then that means that you end up withdrawing some from the normal duty, so the normal duty also suffers. So you have challenges related to that until you stabilize in the response. And then you are able to either recruit new people or to settle in. You relocate some supplies, including drugs, because you cannot keep watching as you wait for maybe the supplier to supply. You relocate and then you take back. You relocate some funds as well. If you, depending on, of course, there is a restriction how much money you can relocate from one budget line to another one, so that you are able to move teams. I mean, like, you have to know the disease you're dealing with. That's the first thing.
True.
Is it a disease where you can sleep and make a decision the next day? No. You have to decide, and decide now. And the decision has to be very high quality. So workload, stress, physically get stressed, the patients get stressed, the health workers get stressed. And that's why I appreciate the Honorable Minister for comforting the health workers, speaking to them repeatedly. We all need that. Because if you are working for a ministry, we all work under the leadership of the ministry, whether you are in an NGO, as long as you're intervening in the health sector. So it's like a child is unwell and then the mom says, it will be fine. Let me tell you, even if it's not going to be fine, you feel fine.
Just feel fine.
So that has helped. Of course, I know you've hosted or televised the presidential speech multiple times. There is even one coming.
On Friday.
Yes, you don't know how comforting that is. Based on your situation, it's very comforting. You're like, I mean, if you've heard from the president and this is what he has said, then you take it as gospel truth, because that's what is going to happen. So consider that everyone, the parliament, has been on this outbreak. The religious leaders, they have been on this. Like everyone. That morale boosts now the response team.
Okay.
Yeah.
Now, I believe you have some wins that you also get down to celebrate in terms of what you have achieved. It's not been a simple task, but yes. It's not
simple. And you know what complicates it? Like I said, when you're mobilizing resources, we all come from everywhere, including the international community. Do not think that it's only Ugandans responding. No, we have so much support from all countries in the world. So everyone is concerned that Kampala is the only city in the world that has Ebola right now. Even if you go to Google, he will tell you the only city in the whole world that has Ebola virus disease. Okay? And anyone can end up here for anything. So the international community is here. So you have everyone coming from everywhere, joining you, and they want to work with you. So you even start by running each other. You have very limited time to build a team, to build a command structure, and then you make sure you start delivering service. So if there's anything we've done well, it's that.
That's
Quickly,
nice.
In a setting where the trust is very low, the city, generally, cities across the world, the populations do not trust like the rural population. So when you call and say, yeah, you got in touch with an Ebola patient, so I would like to meet you and have an interview, they say, which is different from what happens up country. There is some trust. So we happy about that. The other one, of course, I talked about it, school children. Children are the future of this country, but also they represent 56% of the Ugandan population. So they are important stakeholders in this country. Below 18 is 56%. That's over 20 million people. And they contracted the virus. Sadly, they lost one of the pupils. But the other 5 arrive and kicking. They did the exams. Majority of them were promoted, except those in P7 we are waiting to see their results, like the contacts. And because an outbreak in an institutionalized setting is a very complex situation, we were worried that it could be the start of the disaster, but we managed it in such a way that nothing happened beyond that. If there's any win I think we have, it's that. Yeah. And others, there are also others. But that is, they call it what? Melting, heart melting. I don't know what to use, but it was an important important achievement.
Okay.
Yeah.
Doctor, I would really like to say thank you so much for your time. Thank you for the good job that you're doing out there. And we look forward to hosting you further for you to keep giving us these updates, because we surely do need them. Having heard from you, I believe a person out there who is watching you right now has reason and cause to believe that what you're telling them is the gospel truth, because you can't be lying about it. And even we'll get to understand better the mechanisms as to why a scientist will do things the way they do, but at the end of the day, we are safe. Well, that is all we had time for on the topic of Ebola status update, and we'll be giving you more of this as a national broadcaster. We'll be bringing out more of this. We also will use Doctor to get us in touch with some of the students and the people who've been able to survive and get cured of the Ebola virus disease. Right now, I'd like to hand you back to the studio in the auditorium, where Behind the Headlines will be coming your way shortly, because it's just 6 minutes to top of the hour. And stay tuned. Behind the Headlines coming your way shortly.
Further reminds the public to be on the lookout for any persons who may show signs and symptoms of Ebola. These include high body temperature, abdominal pains, diarrhea, vomiting, bleeding from the body openings such as the nose, eyes, and mouth. Please inform the nearest health worker immediately if you see anyone with these signs and symptoms. To prevent Ebola from spreading further, please take the following preventive measures: regular washing of hands with water and soap, avoid handshaking and hugging, avoiding any contact with any suspected Ebola patients. Any person who dies suddenly should not be buried but reported to the nearest health worker or LC1 immediately. For further information, please call the Ministry of Health toll-free number on 0800-100-066 or send a free SMS to your report on 8500. This message is from the Ministry of Health with support from UNICEF and World Health Organization.
UBC, inspiring Uganda.